the immune response, because we ourselves can elicit antiviral immune response to the phage, and also it requires a lot of regulatory approval and also preparation with this therapy. So next, I will move on to microbiome as well. This is something that I know a bit more on modulating the microbiome. So we study the microbiome in diseases, and also we did some FMT as well for C. difficile patient, and we know that they are expanding indication of FMT to other indications, other diseases, and also antimicrobial resistance as well. So when we talk about microbiome, this is not a single concept. We know that there are several things that we are related. So of course, probiotics, prebiotics, and postbiotics are related modulation method. We have fecal transplant, which is the most drastic and also efficient way to change a microbiome. And also we have newer next generation probiotics, and we also have other ways that we can modify microbiome, for example, nutritional or medical nutrition that can potently address and change the microbiome as well. And when we talk about fecal microbiome transplant, this is actually not new. For those who do not read Chinese, they are described in some ancient texts, and I'm sure that maybe in other ancient population texts as well, scripts as well, has been used. So for example, in here that it was described earliest in the 300 AD that some people with severe gastroenteritis, they actually consume, they call it the yellow soup from healthy people to get cured. And from the description, it was quite miraculous. And now from FMT, we know that it is actually quite miraculous. So patients can improve in half a day. So from very sick patient, severe diarrhea, sepsis, to really clinically improve. And so earliest application in modern age was a few decades ago by American physician called Weissman, who described fecal enema to treat at that time called pseudomembranous colitis, which is C. diff infection. So there were some evidence. The landmark study in this field actually was in this study conducted in the Netherlands in Amsterdam Medical Center in 2013, where they recruited only 32 patients and get published in the New England Journal of Medicine. So what they did is compare to, in these people with already recurrent C. diff, so they have at least twice the recurrence. So comparing to people with conventional antibiotics, which is vancomycin, because fidaxomicin wasn't available at that time, comparing to people with receiving fecal transplant, the difference in the cure rate is huge. So you can see that we are talking about a cure rate of 30% versus nearly 90% without recurrence. So miraculous improvement. And the idea, of course, is to replenish the healthy microbiome from the individual. So what they did is they also look at diversity, the microbiome before and after the therapy, and the replenished diversity correlates well with the cure rate. So this remains one of the most rapid and efficient way to change the gut microbiome. That was the landmark study. The literature didn't stop there. So the cure rate of 80-90% is kind of quite established now if we use the right method for people with recurrent C. diff infection. So for example, in this study, they also compare FMT with fidaxomicin as a newer drug, and it's also better. And we did some studies looking at Chinese population receiving FMT, again, similar cure rates, and also we also found some predictor of FMT success. So for example, levels of Candida albicans and also Claudi rarity that could predict the favorable or unfavorable FMT response as well. So FMT, we know, of course, about the safety issue. It is a cocktail. It is unlike conventional antibiotics or single drug molecule. So this is a cocktail or mixture of bacteria and all the components inside. So we don't sterilize them. We only filter them and basically give the filter and screen them and then give it to the patient. So you can imagine there's a whole lot of things that includes that matter we do not understand to these patients. So safety is of course very important. I like to say actually for majority of the patient, the safety profile is quite favorable. Some might develop crampy abdominal pain, some might develop nausea, vomiting, but you can see that overall major complication rate is actually quite low. Nevertheless, of course, there are cases that reports death associated. So aspiration pneumonia is very bad. For FMT, we could develop, deliver usually through the gastrointestinal tract, so to the duodenum through OGD, for example, and we can deliver through colonoscopy. And there are some protocols that use a rice tube in the stomach, and there were isolated cases of aspiration pneumonia. And of course, when that happens, that is very bad. And there were also cases of resistant bacteria that came up as a result of the FMT causing death. So there were issues of warning as well. And you can also see that during COVID time, or even recently monkeypox, it becomes important to look for these organisms in the screening. So screening is extremely important. So that's why before FMT, and as with most of the stool bank now, we screen them rigorously for potential pathogens, and could be region specific. So for example, places that has endemic infection, so we need to add some of these into the screening protocol. The OpenBiome, which is the largest biobank in the US, so the current screening rate, imagine out of 100 individuals that come for a donor for FMT, only 3% of them is accepted because we screen them largely by questionnaires. So people who, because microbiome is associated with many different things, so basically people with obesity, out of the normal BMI, they were excluded. And then remaining, they will undergo laboratory tests and screen them out from that. So out of 100, only 3 of them could be a potential donor because of very rigorous screening. And of course, beyond FMT, people are interested in looking at FMT in different diseases, GI diseases, and also metabolic diseases. And antimicrobial resistance is part of that. So people are trying to do FMT for decolonization to remove the drug-resistant bacteria. So this is the idea, and this is built upon the concept of colonization resistance, that in a community there are natural resistance that against certain bacteria. And if it is against the drug-resistant bacteria, so that could potentially cure that. I would say not a lot of literature, but there are some meta-analysis, mostly some cases report or cohorts, but not very large randomized studies. But this is what we are looking at. So for example, there was a meta-analysis looking at using FMT for colonization of different organisms, and with an aggregate odds ratio of about 0.6. And on the right, you can see some studies looking at different bacteria as well. With some success, but we do need larger studies on that as well. And apart from MIcrobiome FMT, so there are related products as well. We mentioned that people are doing different approaches. Some are taking the chemicals, some are using prebiotics. And on here, I think one exciting area is that people engineer or harvest the components of the microbiome into use. So for example, this Z109 is the spores from non-pathogenic Clostridium difficile, and so using it instead of the FMT to treat C. diff infection. So it was published earlier, so the results are quite good. So there are at least 2 that are actually close to FDA approval. So using different strategy of consortium of microbiome, selected consortium, or some spores, and there are some using different strategy as well. So you can see that the advisory committee actually voted in favor of these. So we might actually hear approval anytime very soon. So these are on here I will summarize. They have different strategies that can combat potentially antibiotic resistance. These are some of the approaches that we mentioned, and I focus on phage microbiome, but of course there are many to come, and I look forward to the discussion section. Thank you very much. These are people I work with, and thank you.
Speakers to sit in their comfy chairs up here. Thank you very much. And well, that was really interesting, and actually, you know, to hear 3 different research perspectives, 3 different approaches in terms of looking at how we can optimize and personalize both therapy and prevention. I thought was really, really interesting. So now we've got a roving mic here. We've got an extremely helpful gentleman who's going to be running around with the microphone. So wanting discussion here, and if you just say who you are and where you're from before you ask your question, that would also be brilliant. So, first questions, please. Over here, thanks so much.
Hi, my name is Isra Farouk. I'm from Monash University. I have a question for Dr. Wong. You were talking about the potential of bacteriophages as antimicrobials. In your opinion, would it be possible to use bacteriophage therapy for COVID-19 associated pneumonia?
Thank you. So as I mentioned, phage therapy is quite specific for bacteria. So some of the phage might target one bacteria or even very specific strain. So I think there's potential, but I think the target is on the bacteria. So if we know the bacteria, so and if there are no better strategies, so I think that could be a potential.
What about in terms of co-infection and preventing secondary infection?
I think if we know the bacteria, then I think that there's good potential. Of course, in co-infection, then there's the virus, there's the bacteria, so we understand it about how it would interplay and of the outcome.
Any other questions?